Hello to everyone watching today's webinar with the Mid-Ohio Valley Chamber of Commerce titled Finding Balance in 2020. I am Jill Parsons, the President and CEO of the Chamber of Commerce of the Mid-Ohio Valley, and I want to thank my co-worker, Nicole Gwynn, for coordinating today's event. Right now, we have all the attendees on mute and ask that you jot your questions in the chat feed and Nicole will monitor those. We will also allow time at the end for open Q&A. So joining us today is Dr. Michael Squires with Audiology Services of West Virginia and Dr. Chris Covert with Mountain River Physical Therapy. And they're going to be discussing their partnership at the Balance Center. Welcome, Dr. Squires and Dr. Covert. I'll turn it over to you.
Thank you. Yeah, thanks so much. This Balance Center has been kind of a brainchild between Chris and I for a couple years. We're really this is the first year we've actually been able to collaborate under the same roof, and we've seen some really positive outcomes from that. But in talking about balance and finding balance in 2020, I think that probably means something different to everybody at this point in the year. Yeah, I know a lot of people that are just rooting for 21 to get here as fast as possible. But when talking about balance, we know, Chris and I know that this is something that really affects patients to a large degree in their life and lifestyle and in quality of life. So I think it's important to getting into this, to share some statistics just to start things out, because I think it's easy and our kind of just take a step back. Our talk today is going to be a little bit more focused on older adults, although this can affect anybody across the lifespan, all the way from sports injuries to accidents to combination of medications. But we're going to focus a little bit more on older adults today, 65 years and older, because that's generally the population that's most affected in terms of balance and vestibular issues or balance issues. So talking about these statistics, they do apply to that age range. In the United States, we found that 1 in 4 adults will fall every year. And that's not that 1 in 4 adults continuously fall once a year. It's just that every year, 25% of older adults are going to fall. And that is a statistic that has stuck pretty well over the years. They boil it down to even minutes and seconds. Every 11 seconds, an older adult is treated in a United States emergency room for a fall-related injury. Every 11 seconds, I mean, that's a lot of adults. What's even more concerning is that every 19 minutes, one of those older adults will die from a fall-related injury. They actually have found that falls are the leading cause of accidental death in the United States. And it's the most common cause of non-fatal trauma-related admitted hospital admittance. That's a huge concern because, those of us in the healthcare field, what we immediately start to think about is, what does it look like from a cost perspective? Well, what they found is, what we find is that things are rising. And that's the big concern and part of the motivation for our collaboration on this. I'm going to eat up some time here in the beginning because these statistics are so important. We look back to 2013 and found that the overall cost of fall-related healthcare expenses was about $34 billion in the United States. Medicare paid about 78% of that, which I think I wrote it down, boiled down to $27 billion. $27 billion from Medicare alone. It's projected in 2020, and these numbers will surface somewhere around the beginning or middle of 2021, but it was projected that number is to increase to 67 billion. So we're going over the course of 7 years from 34 to 67 billion dollars. What that also means is that we're seeing not just an increase in the cost of the healthcare, but an increase in the number of people that are needing those services. I had an interesting statistic written down. If the fall-related death rates increase the same way that they have been, by 2030, we can expect 7 adults to die every hour from fall-related injuries. So I think that, without going too doom and gloom into these are statistics that really should wake people up a little bit. Fall risk and fall assessment is something that should be overtly popular when we're talking about other health related issues. We encourage primary care physicians, emergency room physicians, even like quick care physicians to talk about fall related risks with these patients. And to take a step away from those statistics, it's important to realize what can cause some of these issues. When we talk about falls, and I'll kind of turn this over to you, we've written some of these down, but what do you see as being primary causes of fall risk in the patients that you're seeing?
Well, number one, I think risk factor is what we collaborate on a lot. Of course, it's vestibular, or in layman's terms, inner ear problems. So most of my patients have at least some form of inner ear problem. But of course, that older population that we're focusing on today, a lot of times they have muscle weakness, or even other things that you don't think about, like stiff joints, arthritic knees, arthritic hips, knee replacements, hip replacements. So what that means to us is we need to look at a lot of different factors. So you and I are always going to be collaborating on the heavy hitter, which is the inner ear and vestibular. But if somebody's ankle doesn't move appropriately, or their ankle is lacking strength, that's a big factor. Some of the other things in the physical therapy research world is hip weakness, core weakness, things that we think about sometimes. They're kind of orthopedic, but they can also factor into some of our vestibular and balance patients, because having a weak core, weak hip, they can't adjust their balance as well. So there's an interplay with so many factors with the patients that we have, especially when they're a little bit older. You have to be looking at hips, knees, ankles, the inner ear, and looking at it from a broad perspective. But I think that's where the collaboration piece comes in handy, is you have different professionals looking at different things, and then they're taking an in-depth look at one piece of it, and then we're taking an in-depth look at what we look at and our expertise, and then you get that interdisciplinary collaboration. I think that's why it works so well for this patient population. I mean, in my opinion, you could probably argue it works well for a lot of things, but I think especially this, because it is such a multifactorial problem. And then there's, of course, other things that are a little less common. There's some neurologic problems, such as like MS is a good example of something like that. Strokes is another example, unfortunately, in our area. We have a lot of stroke. It's unfortunate, but we do have a lot of strokes in our area. So that can mess with the vestibular system or play a role. And then I've had several patients with MS, unfortunately, and that can play a big role in this. So it can be from a myriad of things. And then I think some of the other things that you had mentioned too were like a vitamin D deficiency, something you might not think of. That's a risk factor for inner ear vestibular problems. It's a risk factor for a lot of things, but on the topic today, it's especially a risk factor for balance and things like that. And then that can play into some of the other stuff you were talking about with the emergency room, the vitamin D deficiency. It's affecting their balance and vestibular system, but B, then if they do fall, then you got the fracture risk of not having adequate vitamin D. So that goes into the cost. A hip fracture, for instance, some of those big things. A lot of older individuals fracture their hip, fracture their wrist when they have a fall. And then you've got all those downstream costs. Of course, loss of quality of life, loss of independence. And then it's that cascade of things. So when Michael and I started talking about all this stuff, that was our goal, was to bring that to our area. It's more prevalent in certain, like Florida, for example. They have a lot of balance clinics. West Virginia doesn't have that. So where Michael and I travel to a lot of conferences in other states, you start to see what people are doing in other areas of the country. And you're like, wow, there's a lot of these balance centers, but what do we have to offer? So then we started putting our heads together, and we both knew that we look at the whole topic the same, but we have slightly different training. So we try to put our training together to be helping the patient the most. So that's where, you got to look at a lot of factors for falls, I think.
Yeah, absolutely. And to take that kind of a step further, you had mentioned how we kind of basically what we're doing is preventative. We unfortunately we end up seeing patients many times after the fact. So they've had some type of acute experience or vestibular experience, or Jill, like we were talking about earlier, like vertigo or something like that. And then it's been weeks or months later, and we've tested everything, and now this is kind of a last resort.
Right.
What we find is that we can help these people if we can get them in earlier. We can help them one way or the other. We can help them a lot faster if we get them in earlier. The multidisciplinary approach is just such a benefit to that, because if we can get this, get the understanding about fall risk out there, then we can be top of mind after we rule things out, including heart attack and stroke and those certainly more key issues that we want to rule out before we look into those vestibular issues. We talked about cost. The statistic rather shows that an ER visit related to falls generally is about $30,000 to $35,000. Is going to be what is the cost of that visit. We like to think a little bit more on the preventative. You can spend a couple $100 and get some really high quality services that can help to prevent that $30,000 to $35,000 fall. And beyond that $30,000 to $35,000, all of the implications that come after the fact. Are we going to end up needing home health from a hip fracture? Loss of independence is another thing Chris talked about. Really, really important. So I think what we like is a collaboration. We talk about collaboration all the time. So we're actually teaming up with the American Institute of Balance, which is the largest network of healthcare providers that focus on vestibular issues or balance issues. Chris is already certified by AIB, which is the American Institute of Balance. And we are, Carly and I are just onboarding to turn our clinic into a center of excellence. We really want to bring these services to the Mid-Ohio Valley because a lot of people, and not just here, but across the nation, a lot of people dabble or do it. But we want to do it the right way from the beginning. Yeah. And in all of our conversations, when Chris and I sit down and talk about patient care, what's most important for us is the outcome. And that should be the most important for anybody or any patient, but certainly any provider as well. So then that kind of brings us to the topic of, as a patient, what do we do? What do you do as somebody watching this going, yes, I've experienced that, or, I've got a parent or a friend who's experiencing this. What do we do about that? I think from my perspective, and you can kind of opine on this too, I really like to bring this up with your primary care physician. I think as somebody who is there to monitor your overall and global health care, having that conversation with your primary physician and say, look, I watched this lecture or webinar, or I found this information, or I hear them talking about balance. What can we do about that? What we find is that a lot of healthcare providers who are maybe a specialist, they don't necessarily know what to do with somebody who's experiencing vertigo. Once they've checked their boxes, they go, I wish I had another step. And what we would like to do is provide that extra step to collaborate with those providers to really give them that extra, referral or that extra information to help get that patient to where they need to be. So talk to your primary care physician is first and foremost. And one thing that we talk about a lot, and it has nothing to do with the level of care that's provided in emergency departments, but don't rely on the ER to fix the problem. Because in many cases, the ER is there to triage and make sure that, for lack of a better term, you're not dying. And beyond that, they'll either admit you to the hospital, they'll refer you back to your primary care, and then you start that process all over again. And if it's going to be something that's recurring, we talk about that $30,000 number. What's that look like if you're visiting the ER 2 or 3 times in a year from falls? That can not only be a very costly issue, but gosh, you wrap up a lot of time and quality of life in those visits. So, and I think looking into screenings, the CDC has come out with a really great educational protocol called STEADI, STEADI, I believe, for primary care physicians to kind of look into. And it basically gives primary care physicians or any physicians, any healthcare provider at that point, nurse practitioners or anybody dealing with patients, it gives them really valuable information on next steps to take. We're not going to sit here and tell you that everybody in the West Virginia should refer specifically to us. We would love that because we love to see this population and get them to a better place. But I think the important things is just being aware of the issue and being aware that there's something that can be done. Finding a good referral that you feel comfortable with, that you feel is giving the patients the outcomes that they deserve, and really helping to improve the quality of life while giving them excellent services, getting them to a safer place so that the patient and the family can also maintain that independence and feeling of safety for that patient. So do you have any questions just specifically about what we talked about here? Because the next thing we're going to talk about is how this collaboration evolved and what we used to do, but what we do now, and then kind of a plan for what we see happening in the future.
Yeah, so my question and that I jotted in the chat was to talk about a typical patient visit. What does that look like? And maybe that's something you're going to talk about next. And then also, I think you touched on this a little bit about, several of us that are on here today and the folks that are going to be watching this, we're thinking about our parents and they're getting older, and how do we, not that you want to be in the middle of a family dynamic, but how do we broach this subject with our aging parents? What does that look like? And then I was very curious too about the vitamin D deficiency. So, as you're dealing with the patients and stuff, what do those recommendations look like that maybe is some aftercare from the vitamin D piece of it? So those are three of them that immediately, as you guys were talking, I came up with. So I didn't mean to commandeer all the Q&A there, but those are
one. That's great. Well, I think, I don't know what your preference is, but I prefer the Q&A as we go, because I'll forget the question by the time we get to the end there. And these are really great questions. So I just wanted to write them down quickly. I see, what's the typical patient visit look like? And we will definitely cover that. Broaching the subject with a family member or a friend is a really tough one. I think a lot of what we end up doing is counseling. And please remind me what the third aspect of that question was.
The vitamin D deficiency.
Oh,
What's the aftercare for that discussion, or advice, guidance that you encourage people to do so that maybe that becomes less of a risk factor for folks, and you can, take that one off the list to say, what you're managing that.
Sure. So I think if it's okay, let's start with broaching that subject, because then once we broach that subject, then we can talk about kind of what our collaboration looks like in vitamin. We'll mix kind of some of those typical healthcare issues that we find. We can kind of mix that in with that. Broaching the subject is tough. What we do in audiology is I jokingly say we sell healthcare that nobody wants. Nobody wants to believe that they have a hearing loss or any type of deficit. Nobody wants to admit or believe that some level of independence is going to go away. And some of this, I believe, is generational. I think we've talked about that in the past. But when you talk to a patient, and it depends on what generation they're a part of. When you talk to a patient about, hey, it looks like you're losing independence, that's not normally a very welcome conversation, right? And so we have to be very mindful of that. Especially, we all know those people. We all have those people in our lives that are, in their mid to late 80s or early 90s who are, very vibrant, very busy, and still very active, and they want to remain that way. And then we also have those people in our lives who were like that, but we're starting to see a shift, right? And I think that's probably the time when we need to have that conversation, is before we see that shift and say, look, why don't you get a baseline screening and see where everything is before it becomes an issue. I am a huge advocate for preventative healthcare. I think that in some cases, insurance doesn't necessarily like to pay for preventative health care, because you get into the topic of whether something is proven or whether something is still experimental or something like that. And that's a whole different topic for a different day. We could chew up an hour just ranting, I think. But preventative healthcare, even though in many cases it's out of pocket, is so important because it keeps you from those $30,000 to $35,000 hospital stays. So how do you bring that topic up?
Well, I think, in my opinion, I think there's a misconception, and I don't know if it's generational or not, but the older people, I think that they just have to live with it or deal with it. I think, and they don't. I would say that the treatment for this types of issues have come a long way. So maybe when they were like in the younger, there was nothing that could be done. You would go to your physician, you were dizzy or off balance. It's like nothing was done back then, maybe. That's kind of what I get when I talk to the patients about it. So I think a big thing is now there's a lot that can be done from a diagnostic standpoint, from audiology. You can pinpoint what the problem is exactly now. And then that allows us to individualize the treatment approach. So it's very effective even up into your 90s.
Right.
We treat multiple people up into their 90s. So for me, that's a big thing. I hate to hear it when I hear people say, oh, I'm just getting older, I have to deal with this. I have to be dizzy or I have to be off balance. That's very rarely true. I won't say it's never true because that might be a little bit more. There are things that happen physically that we can't do anything about, but it's pretty rare, to be honest with you. A lot of our older people have a lot of capacity to improve. And I think that's a big piece of it for me. Now, from a physical therapist perspective, the best way for me to get them to do what they need to do is I try my best to tie it into something that's important to them. So if that's, it could be anything from playing golf, it could be walking with their neighbor, it could be getting in the floor and playing with their grandkids. You have to find, in my opinion, what's important to them and then tell them we have a solution so you can either get back to doing it or maintain doing it, depending on what the circumstances. Hopefully they're not to the point where they can't do a bunch of stuff already, but we both know that happens sometimes. So sometimes by the time we get people, it's already they can't do X, Y, and Z activities that they enjoy. So my talk with them is usually balance is adaptable. There's things that we can do to adapt your balance. There's things we can do to help dizziness. And then I try to tie everything that we're doing back into, you want to play with your grandkids, you want to get back out on the golf or whatever they happen to enjoy. So I think tying it into what they care about, because what I care about may not be what they care about. I might be doing some balance screening test that I think is important. Like, can you walk across to the clinic at a certain speed, or can you get up and down from a chair a certain way? Well, they don't care. That's kind of, I care because it helps me measure their progress, for instance. But I have to find something that they care about, or otherwise they're going to be like, why would I do physical therapy for this? So I think that's a big key from the therapy perspective.
Well, and I mean, you kind of hit the nail on the head. We are a communications field first. In audiology, we talk a lot about hearing loss. And I find that although the statistics are wildly compelling, people tend to ignore statistics in hopes that it'll just go away or just not affect them. A mild untreated hearing loss will increase the risk of falls by 300%. I mean, and that is a huge number. Untreated hearing loss has all kinds of secondary applications like cognitive decline or memory loss or depression and anxiety. And then you add something like fall risk on top of that. So, injury or, hospitalization or just doubles or triples the risk of things like depression and anxiety. And we don't want to see that of our loved ones, and we certainly don't want to see that of anybody else's. So broaching that subject has to be done delicately. But I think that I think fall risk is a lot easier to market to somebody because it feels very real. Let me put it this way. When we talk to a lot of patients, we ask them, are you worried about falling? The difference between the question, are you worried about having hearing loss, and are you worried about falling? The way that people react to that question is very different. And people do get worried about falling. So let's kind of quickly shift in the interest of time, just kind of shift to how we approach patient care. First and foremost, and I see, do you need a referral in order for the assessment? It really just depends on the insurance. That's a really good question. It really just depends on the insurance. Now, Medicare requires a referral to an audiologist regardless, but some Medicare supplementaries kind of will stand in place and say no. So having the patient or the physician call and ask, the silver bullet is just always having a referral. That's just easy. You can cross that T and dot the I. Or the patient can call and ask, depending on their insurance, we can let them know. But once a patient is scheduled, it's funny, people get so worried about falling, but the testing is so easy. And it's getting easier. We're working on some new protocols to really kind of have it a once and done thing where patients don't need to come back and back and back for further assessment. We can do it all at one point, at one visit, and then all of that information gets transmitted between the two of us, between the two clinics, so that it's an immediate assessment. It's an immediate result, and we know the plan of care. We're no longer throwing darts, or what do they say, throwing spaghetti on the wall and hoping it sticks. Yeah. We're directing that care specifically for the patient. So what we assess as far as audiology is concerned is we will take a really good deep look at the entire auditory system. The auditory and the balance system are interrelated. They're connected. And if you really want to split hairs, they're not just connected, but they work together. So one can affect the other and vice versa. So we take a really good, deep, involved look at the balance center and the auditory system to see if there's something that anybody's missed up until this point. And if everything looks really healthy and everything's working the way we would expect it, we start looking at risk analysis, like with hearing loss. Well, it looks like there might be a hearing loss present. We need to assess to what degree that hearing loss might be contributing to lack of spatial awareness. Why is your brain why is your brain having difficulty processing this environment? It's probably the hearing loss. Once we've kind of checked that box off, we move on to weaknesses. We look at what each of the ears are doing. Are both ears pulling weight equally? Are both, or is there a unilateral or a weakness in one ear or the other, or in both ears? That information is probably most valuable in the terms of us communicating, is like, where are we identifying weaknesses in this system? And that's, I think, where we would like to pull in more collaboration with other providers. We talk about vision, we talk about proprioception, which is, how our brains and our feet and our nervous system is relating that information to the brain. Can our feet feel what's underneath us? And then that's kind of where Chris comes into play. Once we've identified all of that stuff from the diagnostic perspective, we can walk the patient through what we have found and then literally walk them right down to Chris. So we can just let him take over immediately. Otherwise, that not only improves our outcomes, but it helps with loss to follow-up. In previous years, the way that we collaborated was, this is what we think should happen. We're going to make a referral over to Mountain River Physical Therapy. Hey, did they show up? Well, we've never seen that patient, So, you have the information, we know what to do with it, but if we don't follow up, then there's nothing we can do, right? There's a certain level of buy-in and trust in that process. And I'll let you kind of take over from there.
Yeah, and then once we have all that data based on how the inner ear is functioning, how that it's affecting a person's equilibrium, and then of course testing for what Joe alluded to earlier. You test to see if anything's going on with the benign positional vertigo type diagnosis. So that's another thing that we can pinpoint, and that's easy to treat, fortunately. So once we get it pinpointed, then we look at some of the other things that I alluded to, like we're doing some balance screening tests. So that would involve having patients walk in different ways, change directions, see if looking left and right changes their balance while they're walking. So doing some validated balance screening type tests, some tests that we can score the patient on. And then not only does that give us good data in addition to what audiology has already provided us, it also gives us a way to see how are they doing with this task. And then that goes back to what you were asking earlier, like keeping the person kind of bought in, or, broaching the subject is, well, the first day, if they can barely walk and do the task that I'm asking them to do, and then 2 weeks later, they're doing it with great ease, then they're hooked in and they're on board, because they're like, wow, I haven't been able to do this in a long time. And then they see those positive changes, and then they're much more willing to, let's give this thing a try. And then once you've got them hooked in, then you can really get even better outcomes, because then they start doing the things you ask them to do at home, and doing the little balance exercises that we've individualized for them. But I like the word that Michael used earlier. Individualization is important for this kind of thing, because even if they're 90, we'll use that as just an example, they're not, I mean, they can be completely worlds apart on one 90-year-old versus another 90-year-old.
Mhm.
It can be one ear versus the other ear, or it can be, then they could have some of the muscle weakness that we talked about earlier. So it has to be customized based on the test findings,
Sure.
and then also their ability level, so that it's doable for them, and find that starting point that they need to be able to be successful, I think.
And what's really neat is, we had talked about like what's this going to look like in the future? This is our first, of course it happened in 2020 amidst everything else, but we're just now rounding the corner on our first full year with a collaboration under one roof. And we've learned a lot. We've learned a lot about what patients expect. We've learned a lot about what we expect out of this type of collaboration. And of course, that collaboration with the American Institute of Balance is going to be incredibly beneficial to how we address patient care for balance patients. And one of the things that comes out of that is a difference in protocols, where we can actually bring a patient back and assess if that weakness is closing up. It's not something that we're able to do right now, but it's something that we are, investing in new techniques and new equipment, so that we can kind of push this balance center into the future of what balance should really look like, making it easier for the patients, certainly more precise. But we'll be able to say, look, you're 40% better than you were 6 weeks ago. Keep it up. And having that kind of having that information encourages those patients. Listening to you talk, I'm thinking like, as an example, it's like, being really surprised at how flexible you are after you do yoga. You know what I mean? I've done yoga for 6 weeks. It's amazing. I can touch my toes again, or buying into a diet once you see that you're losing weight. I mean, that's that encouragement, that physical or tangible encouragement is so important to healthcare. Otherwise, you get we've had this. You get patients that come back and say, "Well, all he's having me do is, turn my head left and right. I could have done that on my own." Like, well, I know, but it's different than what you think. The brain is a powerful thing, and you have to rehabilitate that and let it take over for what's been happening. So, and then of course we talk about some of those more typical pathologies, if you will. Jill, you had asked about vitamin D deficiency. Vitamin D deficiency is not necessarily something that we test for in our clinic. That's where the collaboration comes into play. That's why it's so important for other healthcare providers to be acutely aware of how their specialty can affect a person's balance. Because literally anything, for example, I shouldn't say anything, but we talk about the rate of diabetes in this area. Diabetes is definitely something that we talk about quite frequently with our other healthcare providers. And it can affect the vasculature, that fine vasculature in the inner ear, meaning it can affect hearing and it can affect balance. Other cardiovascular issues are the same way. So having each healthcare professional able to identify how their specific specialty affects balance allows us to collaborate with them so much easier, because unfortunately, or fortunately for us, in some cases, we don't necessarily have the ability to order a blood panel or do an MRI. That's where we rely on other physicians and healthcare providers to help us with that and collaborate. So primary care physicians or nurse practitioners, orthopedic physicians or surgeons. Neurology is a really big one. So, those collaborations are so important. But it's amazing. Vitamin D deficiency is more common than I think what we think, more common than we realize, rather. And vitamin D deficiency will cause vestibular issues. So being able to identify that quickly is of utmost importance for patients.
And then I think the other thing it does is if once that's addressed, it allows them to be more successful in our clinic.
Absolutely.
So like you said, whether that be the primary care physician or the ear, nose, and throat physician or whomever that is, if they're providing a supplement based on the blood panel or something like that, or if it's a diabetes special, if they're helping them keeping their blood sugars under control so that they don't get neuropathy in their feet, for instance. So if they start to lose sensation in their feet, it makes it harder for us to get an optimal outcome. So even talking to the patient occasionally, and they don't like this, speaking of talks they don't like, it's like, you got to watch keeping your blood glucose under control.
Yeah.
And that's not something you would think of for physical therapy and audiology, but it's crucial to us obtaining the outcome. So occasionally I have to have that talk. They'll tell me their blood glucose has been out of commission for like 2 or 3 months. And I'm like, well, we need to get that in check if you're going to be successful with your balance treatment. So that's another thing where that interdisciplinary comes into play. Now, I can't specifically give them the medication that they need or things like that, but they can talk to a dietitian about their diet or get the appropriate medication from one of their physicians or something like that. And then I saw Sharon, she was asking, and yeah, and that's correct, Sharon. They start out with audiology testing. They usually typically get some type of hearing evaluation and then that in-depth assessment of the vestibular system that Michael was talking about, looking at it from different angles. And then as long as nothing is a red flag, so to speak, like it needs to be an immediate trip to neurology, that really doesn't happen too often.
Right.
Then yes, most of the time they're going to make a trip down to physical therapy. And then we'll do our balance screening, whether it be muscular strength. And then we'll take all that we find in our PT exam, take that and combine it with the audiology exam and take all that technology, use all the technology, and then do the more basic testing in the PT clinic. And then we individualize that into their treatment plan. And then we reassess periodically and see how it's going. And then if we need to, we'll have we'll get together and discuss the case. Do we need to bring in somebody like a neurologist? Can we handle this one in-house? A lot of times they've been to a physician. So a lot of the bad, scary stuff, so to speak, has been ruled out.
Sure.
So then we can go right into what we think they need. If occasionally, it's not frequent, but occasionally we'll have to refer them back out to a physician for an MRI, for instance,
right,
or something of concern.
Well, and there's a lot of things too that I think there's common diagnoses that in some cases are either over or misdiagnosed. We look for things like, or completely missed because they're not that common. We look for things like cochlear hydrops and Meniere's disease, benign paroxysmal positional vertigo, labyrinthitis. I mean, we're really taking an in-depth look at this before they get to that physical therapy part. Sharon, the way that I like to think of it is functional assessment versus a more in-depth or technical perspective. So what we do is the technical stuff. The patients just sit there and then we go zzz, and we really get into that vestibular and auditory system. Whereas we realize that that's not real world, right? If they're sitting in a chair for the whole assessment, how are we assessing if they're going to trip over the rug, right? That's where physical therapy comes in. It's like, think of it like a hearing assessment. You're sitting there listening to beep, beep, beep. That's not, I can't communicate with my grandkids or I can't hear in background noise. We have functional assessment for that, but we can't get to that functional assessment and have any meaningful results until we have that more technical look at everything. Any other questions?
I didn't see anything else come out. Nicole, did you get any others?
Cool.
Deanne, any questions too? I was watching here to see.
It's okay. While we're waiting for that, we kind of kind of do a short wrap up, the Balance Center is something that we're really, really proud of. It's something that is very different, and not the idea of the Balance Center, but the way that it's executed is what we really feel is different than what the Mid-Ohio Valley certainly has experienced. Our state has had a couple good balance centers in it, or does have a couple good balance centers in it, but they are few and far between. But there are a lot of people who claim to be a balance center. The importance of doing it right the first time cannot be overstated, which is why we really push for collaboration, and those collaborations with companies like the American Institute of Balance, the people who are really, really doing it the right way, and give us that extra push and that extra backing so that we can really take care of our patients in the best way possible. Those are the things that we get really excited about with talking about collaborations and patient care, because look, if we don't have the outcomes, there's no sense in doing the testing. There's no sense in us putting all the effort and time into testing these patients if we can't then say for certain, this is what your next step should be. So, we appreciate the opportunity to come and talk about the Balance Center. It's something that we feel is really important, and I would think that patients that are worried about falls would have a concern about as well. So we want them to know that you don't have to live with it. You don't be told that you have to live with it. There's definitely something that can be done, or we can look into it, and we're excited to help get on that path. I see one question there.
Yes, Deanne dropped in a question there.
We adapt to these challenges. I'll let you take that one, though. It's kind of more in your wheelhouse.
Well, usually the answer is yes. I mean, if you're talking, and specifically in regards to balance, a lot of our people, we talk about them sometimes separately. Like we'll talk about, is their balance issue due to a foot problem, or is it due to like the vestibular problem? What really happens in real life is there's usually a combination of things that we need to address. So when you have a physical issue, such as an orthopedic problem like a Charcot foot or a missing bone in a foot, or like an old ankle fracture, or things along those lines that affect the mobility of the foot and ankle, what you have to do is determine, is the foot and ankle weak, or is it lack ability to move, or is it just a balance proprioception thing? So what Michael alluded to earlier is we have these what are called proprioceptors in the bottom of our feet that tells us where our foot is in space, or where it is hitting the floor, or what type of surface we're on. So a lot of times, if the person still has normal sensation in their feet and those proprioceptors have not been severely damaged, you can train those receptors to communicate better with the brain and allow the foot to adapt better to different surfaces. And we do that, like there's some simple ways, like it doesn't have to be super complex. We have foam balance pads, and you put the person on there that has a foot issue, and their foot has to learn to adapt to being on an unsteady foam. So the whole time they're on that foam, the little proprioceptors are adapting to that surface and learning to adjust their foot. So it could be anything from that with what your question was. And then it could be like you actually have to physically try to get like the ankle to be less stiff or something like that. So what I would say in a nutshell is usually you can improve, and it's not always 100% with your specific question. But what I found is if you get 40 or 50% better, that's a big game changer for most folks. So sometimes a Charcot foot won't allow you to get 100% better, but it typically doesn't prevent you from improving at all. So I'd say some level of improvement, typically you can still maintain or gain. That would be the best answer.
I think too that, and I'll let you kind of correct me if I'm wrong, the benefit of actually doing this in the clinic, so many people will go to Google first. They'll go straight to WebMD and it says to do this or do that. The benefit of having it done in the clinic, at least the first time, or to get some guidance for what you can do at home, is that it's done in a safe and controlled environment, so you don't actually end up running the risk of injuring yourself further.
Right.
I think, Jill, I was thinking of this I hope my mom does not watch this, but my sister is an audiologist as well. We're not very original in my family. My dad was an audiologist, but my mom was not. And she ended up with a similar situation that we talked about earlier, this benign paroxysmal positional vertigo. And my mom is a diehard technology fan, went right to YouTube and calls me and says, it's not working. What's not working? I can't get it to, I can't stop spinning every time I move. And, I said, walk me through what you're doing. Wildly wrong. The interpretation of what to do. It's not, most people think, well, I just threw myself back and flailed my head around. And, and in some cases, again, throwing spaghetti against the wall, it might stick. And I hope it does. But in many cases, it doesn't. And having that professional guidance of somebody either guiding you through it, doing it for you, or watching you while you do it to say, don't do it this way, do it this way. Think of it like weightlifting, right? And Chris probably does it. I don't, my wife would tell you, I'm not much of a weightlifter, but what I do know about somebody who is doing personal training, I had a best friend who was a personal trainer, and he always talked about making sure that people's form was correct, because you can do more damage by not doing it correctly or learning how to do it correctly than you can, just not doing it at all, or having some guidance on that. So having that guidance in the clinic is really important to keeping you safe and preventing further injury, but also giving you those resources to be able to do it at home if it's appropriate.
Very good. Well, great information. I think the biggest takeaway for me today was the whole idea of a baseline screening before. I mean, I think that's just a great idea. Get the referral from your primary care physician or your PA or the nurse practitioner that you see that manages kind of your medical history, and get you a benchmark to see where you're starting out with. And obviously you have the opportunity to get your hearing checked and see what's going on between your ears. And then if there is something going on, that there's a balance issue or something to remedy even before you have a balance issue, the opportunity then to partner with Mountain River Physical Therapy with Dr. Covert is a wonderful opportunity, because it's just right there. And then we're going to give you some guidance and exercises and follow up with you. So great information today. Thank you so much. I'm so excited. I think people are going to be very excited to learn about this opportunity here and how lucky we are in the Mid Ohio Valley to have your resources and your expertise and your vision to want to make this happen, because at some point in time, all of us are going to be there needing these types of services, and that we can stay in our community and have this level of care taken care of is so important to all of us. So thank you. Any final words that we have?
No, I would just say, sorry, I jumped right in. That's my personality. I would just say, a big thank you, Jill, to you and to Nicole and to the chamber. This type of information is important to get out, but sometimes it's difficult to get out because people don't want to listen to it. It's not something that anybody's running up to tables at health fairs to learn about. Like, tell me how I can not fall. But the baseline screening is wildly important. Talk to your primary care physician. Get as many baseline screenings starting around that 55 to 60 years of age time frame. Because what we know about statistics is that everybody wants to start those statistics at 65. That's when things kind of really have a tendency to accelerate. So we just want to monitor that and keep people as independent and healthy as possible. Get as many baseline screenings as you can for that routine health screening, because we want to have something to compare it to. This is where you were and this is where we are. That's how we can monitor that change and get you on a better track. And as things progress and as our protocols change and our services improve, we'll let the chamber know all about it. And hopefully we can do this again in the future when things are even more different.
Absolutely. Well, we thank you so much for your time today, for your expertise in this webinar. I would be remiss if I didn't share that Audiology Services and Mountain River Physical Therapy are wonderful members of our Chamber of Commerce and very supportive of everything that we do. And yes, this does seem a little outside of the realm of our typical lunch and learns, but I mean, this isn't something necessarily you're going to go back to your business and say, I'm going to implement a balance protocol with my
But you could
employees.
call me if you
But
want
you
to.
could. But we're all human beings. We're all living with these types of situations. We'll have family and friends. That this is a great, valuable information that we can share with one another. So again, thanks everybody for your time today. I'm so excited for folks to get to watch this as soon as I hit the stop record button and we will get it loaded. And I hope, yeah, Michael, I hope your mom does get to see it.
Yeah. I'll send it to her, I'm sure. She'll
will.
find it.
Thank you guys so
Thank
much.
you.
Thank you guys.
Thanks.
Have a great day.